the issues are, and ultimately we will be able to link it up with overall health data governance work that is happening elsewhere as well. So on the part of the Health Data Collaborative, I think this is a session for knowledge exchange as well as an opportunity for us to share ideas and see where we can complement, we can collaborate, and also have a plan of action at the end, so that this will not be an end point, but this is something of a beginning, so that we can collaborate further and bring many other partners to the discussion. So with that, I would hand it back over to Ali. Thank you for initiating this and also moderating the discussion. Thanks, Ali.
Thanks a lot, Pendula. Next, I will ask Dr. Mary May, the Director for Data for Impact at UNAIDS, to share her perspective on why data governance matters for HIV and sexual and reproductive health and rights. Mary, over to you.
Thanks, Ali. And yeah, I think a couple of us tripped on the password coming in, so hopefully we'll get more people joining as we go through. I also want to just thank you for organizing this, and thanks to HDC for partnering with us on this. I think it's so important to be coordinated across disease areas and public health topics on this topic. I have 3 points that I just wanted to make, and the first one is really around the timing of this session and how critically important it is, as we saw earlier in this year with the sudden ending of US support in January. We saw so many systems closed down overnight or with very little warning. HIV treatment data was actually taken offline in some countries for a few weeks right after the US shutdown. And that had huge impacts on people's lives, as clinicians didn't know what regimens of drugs they were on. They didn't know where stockouts were. The whole HIV response in some instances was flying blind. So there are major consequences when that governance piece is not strong in countries. And so we need to be thinking about that clearly. So as we think about governance systems overall, we need to be really thinking about the ability to provide health services within the government, but also across stakeholders. So we're avoiding duplicate systems. Also making sure that they're integrated across public health areas. So we can't have one governance system specifically for HIV, the next one for sexual and reproductive health. So that whole integration of one governance system seems really important at this point. The second reason why this webinar is so timely is because we're seeing very quick advances in digital innovation. And while we know that's definitely the way of the future and will and can transform how we produce and analyze data, we need to be thinking very clearly about how we manage the digital innovations and focusing in on confidentiality, especially from the HIV perspective, making sure that people's identifiers are either removed or protected when databases are shared. Simple precautions like avoiding software that requires licenses or steps to use data that doesn't allow individual identifiers will be really important going forward, especially with the licenses. You know, if you think of a country having to update those licenses every year, they're no longer independent. They're dependent on the updates of that software and paying for those licenses. And so it's really important that we be very careful of red flags. Having some sort of technical working group that can review those red flags regularly on all sorts of technology will be important. My final point is a request to everyone that's on this call, and that is to really listen through what the countries are telling us in this webinar, to think about what are 3 actions you can take away, either for your country or for countries you're supporting, on ensuring strong data governance going forward. One example might be thinking about community data collection and how we support communities to have their own governance systems, but also how we then use that governance system to work together with the national information systems. Another one that's close to my heart is household surveys, and thinking about how do we make sure that countries don't rely on that external TA, but instead they build on the guidance that's been developed over decades of doing household surveys, getting those tools directly from an online database and using those to produce survey data transparently and making those data available, but without that reliance on an external funder. So in summary, I think we know there's existing data governance systems out there, but we need to think in this webinar about how do we support and build on those systems across public health areas to ensure the best public health outcomes in the future. So back to you, Ali. Thank you.
Thanks a lot, Mary, and important issues to have in mind, starting not from this webinar, but maybe we continue from what we have been doing at the countries and the global, and just hopefully boosted by this webinar and moving forward. With that, I would like to ask Vikas Dwivedi, I hope I'm not butchering your name, who is the co-chair of the Digital and Governance Working Group of the Health Data Collaborative, to walk us through the basics of health data governance. I know that this might not be news for many of you, but to put all of us in the same footing, it would be helpful to listen to Vikas. Vikas, over to you.
Thank you, Ali. Thank you very much. Is it possible that I can share my, oh yes, I can share my screen now. Perfect. So yeah, thank you, Ali. Thanks everyone. My name is Vikas. I am one of the co-chairs of the working group. I hope you can see my screen now. Yeah, okay, great. So we have been working closely with the Health Data Collaborative. There are multiple groups. One of our groups is looking at specifically data governance in the digital age. And that's kind of essential because, as we know, that you know, with more and more digitalization happening in the health sector, the health the data that is being generated during this process is.
Yes, sorry, I don't know whether the slides can be seen. Others can see, or
You cannot see the slides?
I can see them. I don't know.
sorry. Okay, great. So it's my end. Sorry.
Okay. All right. No worries. So with the digitization happening, there is a lot of data that is being collected, and also referring to what Dr. Mary said, that there's a lot of duplication happening in this space. So with the health data governance framework in the health sector, we are trying to look at those issues, and the idea was that to generate a framework that countries can look at and apply in their local setting and context, to be able to look at those issues and make sure that that whatever data is being produced, stored, analyzed, used, and shared is properly being sort of governed or managed in the right way. And to add to that, with AI coming in the health sector, this really becomes more and more important, as much of the data will be used for these to feed into these algorithms, and for automation and other purposes. So our group has 60 plus members across UN agencies, across ministries, across implementing partners. And over the last couple of years, we've been meeting almost every month, and sometimes every other month, to work on this. We have looked at sort of three aspects of one. We did a landscape analysis of what is happening currently in the country. So a couple of case studies. We tried to map these examples across these different countries. I'm not going to go through each and every country example, but that's available in the slides that I'm happy to share. We collaborated Transform Health led the development of the health data principles. So we collaborated in that process to provide feedback and to support that initiative and make sure that the framework is aligned to those health data principles. And finally, after a couple of years of time investment, energy investment, we now have a draft framework which is ready and very soon will be available for wider circulation and for whosoever is interested to adapt and apply. And just for reference, I also wanted to highlight that these frameworks have been designed. This framework has been designed sort of to set the condition for to facilitate the what we call the data life cycle or the data journey that looks at collection, use, reuse, storage. At all these stages, what are the privacy concerns? How we can make sure that the personal identifiable information can be safe and should be safe in the aspects of interoperability, as well as security, integrity. At the same time, making sure that we are using it to improve our health services. So over the last couple of years, the working group has met almost every month, and then sometimes every other month. And we also took the opportunity of existing either forums or meetings where we could bring people together to get their inputs on this development of this framework. So definitely the health data principles is one of the product. The leadership event, the Global Digital Health Forum, which some of you may know, is organized every year. We've done 2 workshops and then some virtual workshops, including the guide convening to gather inputs for this. So just quickly, I'll walk you over to the data principles first, which actually sort of presents what and thanks to Transform Health for taking the lead and helping develop this. There are 3 groups of areas: protect people, prioritize equity, and promote the value of health. And for data systems in health, we need to make sure that every individual in that system, their data is protected. There is trust both from the community side, the individual side, as well as the health provider side. Ensure data security. From the equity perspective, the data rights and ownership are established and well understood. Equitable, it promotes equitable benefit from that health data, so nobody is left out, and make sure that we can actually reach out and be more inclusive in our services. It's still on the promoting health value, facilitates innovation, promotes data sharing and interoperability, as well as enhances decision-making and health systems and services. So the current framework has 3 core domains: regulatory and policy standards, structural procedures, mechanisms, and the technical and interoperability standards. And why we looked at these 3 core domains is we need the law and policies in place to provide that enabling environment for health data sort of governance principles to be implemented. We need the structures, the governance bodies. Is it the Ministry of Health? Is it the national e-gov agencies? How do they work together? What are the day-to-day mechanisms if I come as a researcher requesting for data? What are the procedures for getting approval to use that data and making sure that that data is not personally identifiable? And then the various technical aspects that I'll walk us through. So first, on the regulatory and policy standards, looking at the legal compliance, the data protection, ethical guidelines, consent management. A very good example of consent management and data protection privacy is the HIPAA law in the US, which actually defines the elements of data that cannot be shared and can only be shared after individuals' approval and consent. And now we've seen during COVID, the cross-border data transfer is really essential from an international health regulatory perspective as well. And when we travel to other countries, that data should be, should be protected and accessible if I need to use that in another country. Structural and procedural, the governance bodies, the roles and responsibilities should be clear, who's doing what, accountability mechanisms, stakeholder engagement, transparency, the procedures, those all should be, there should be a process that is in place, and people are assigned the responsibility of making sure those steps are undertaken. And then on the technical side, the data standards, interoperability, which is essential for interoperability. Data quality management, which also points towards the trust in that data. What the data that I'm using, what is the quality of that data for me to be able to make those decisions. Storage and backup, metadata and provenance, algorithm and governance as well, with digitization and AI. I'll just quickly explain this, maybe by giving some small examples around the data life cycle. We also call it the data journey, which kind of has broadly 6 or 7 steps, from data collection, transmission, cleaning, sharing, analysis, and taking action. All these steps are sort of pretty common in most of our context and settings. So making sure that while data collection, there is consent and ownership, which is clearly stated and understood by both parties. We need to be very clear who does that data belong to, and are actually taking the consent before collecting that data. Transmission with interoperability and data sharing, the privacy and security aspects should be made sure that in every system there are policies, again, from the policy perspective, from the law perspective, that those laws exist. And based on those laws, we have the procedures and steps to manage that. Data cleaning, the quality steps, provenance and trust, making sure that whatever data is available is inclusive and of high quality for us to be able to analyze and make decisions. The personal identifiable information and encryption, even while data sharing or transmitting from one system to the other. During analysis and AI, equity, inclusion. And again, maybe it's not only for analysis and AI, we also need to make sure that equity and inclusion is also part of during the data collection phase, as well as taking action that no one is left out, and we make sure that the data is inclusive and helping us identify issues around equity and making sure that we can improve our service delivery to the marginalized or to remote areas of our communities. And the very most important and like not the end, but again a very key step is the use for decision making and reuse for further analysis and research purposes. But that's kind of very essential that with all the digitization and AI, there are various tools that are being now available for health to facilitate that. So make sure that all that data is used and reused to take action for improvement. So I'll stop here. There are some references. And as part of the slides, I have still left the country sort of examples that people can refer to if they're interested. Thank you. Over to you, Ali.
Thanks a lot, because it's, as all of us appreciate that this is a wealth of data that it won't be possible to go through it at 10-15 minutes. Really appreciate what you put there, and to answer the questions, yes, we can. I assume that we can share your slides, because all right, that's great. So as per the agenda which was shown earlier, now we go to hear from countries on the country spotlights. that would be a discussion that will be moderated by Kristen Matheson, who is the Deputy Director and Policy Lead for Transform Health. As per the agenda and the invitation that was shared earlier, we wanted to listen to hear from 3 countries, from Tanzania, to share their systems on data protections and sharing framework, from Kenya on Afya KE and the unique patient ID for HIV continuity of care, and from Zambia on community health information system. From Tanzania, we were to have Dr. Prosper Neju, but unfortunately, because of the some challenges, he wouldn't be able to join this call today. But they have promised to join for a future call on this issue. From Kenya, we have Dr. Joyce Wamkimwe from a digital health agency at the Ministry of Health, Kenya, and from Zambia, Mr. Mwango Mutale, who is the Chief M&E Officer at RHIS, Ministry of Health, Zambia, is to join the panel. Kristen, over to you to manage the panel and inviting the panelists to join.
Thanks, Ali, and thank you to UNAIDS and the Health Data Collaborative for organizing today's session and for inviting me to be part of it. It's really an honor to moderate this part of the session on looking at country experiences, which are so important as we look from how we move from policy to practice to really advance health data governance within the space of HIV and sexual and reproductive health and rights. This is a really important issue for Transform Health, particularly looking at the need, building on what Vikas has said, really the need for ensuring those robust frameworks in place at national level to really, and including kind of those legislative frameworks and then the broader data governance frameworks around that to really ensure we're safeguarding data, upholding rights, but also facilitating the responsible use of that data to improve health outcomes, which is essential to build that public trust in our health data systems, and in the digital systems, as Vikas mentioned, realizing that that's really accelerating the amount of data that's being generated, but also consumed in the digital age. So as Ali mentioned, we're really lucky to have 2 brilliant speakers joining us today to really share the rich national experiences on the issue. Dr. Joyce Wamwike from the Ministry of Health Kenya and Mwango Mutale from Ministry of Health Zambia. This part of the session, so we'll start off first with brief presentations from both of our speakers to share some of their national experiences, and then we'll go into more of a discussion to really unpack and look more deeply at some of the issues around this. So if I can first hand over to Dr. Joyce to share the experiences from Afya KE and the unique patient ID for HIV continuity of care. Over to you, Dr. Joyce. Do we have Dr. Joyce online? If not, maybe we can start with Mwango from Zambia about the Community Health Information System. Do we have Mwango online? Sure, Ali Pandula.
Ali may be able to confirm.
Just a second. I understood that Dr. Joyce was on the call. Maybe while while we ensure that our panelists are joined, maybe we can have the questions to Vikas, and I see a couple of questions in the chat, but it would be helpful to open the platform for questions. Please raise your hand or put it in the chat for Vikas to answer, and see that if we can manage to find our panelists. Thank you.
Great. Would you like me to facilitate this? I'm not sure Pendula is coming in.
That would be great, Kristen.
Perfect. So I think the first question we have in the chat, Vikas, is where and how can community data feature in the data governance architecture?
Thanks, Kirsten. And thanks. I think this question is Medine, if I'm not pronouncing it wrong. Thank you for your question. Yes, very important. And I think I personally believe that community data and facility data should be part of one architecture or one ecosystem. And if services are being delivered at the community level, the data also need to interact with health facility data. So I would not separate the community data aspect from facility data, and try that we have a coherent architecture that actually brings together that ecosystem and looks at health facility and community data together. I hope that sort of answers your question.
Yeah, thanks, Vikas. And also, as we move on to the next question, really encourage others to, if you have any other questions or reflections as well, based on what you've heard and your national or organizational experiences, please do raise your hand to share your perspectives, ask any questions, so we can really open up and have a dialogue amongst all of those on the call today. So I'll just move on to the next question as others get their questions and comments and reflections ready. So from Abhishek, in low resource settings, sometimes it may not be possible to adhere to all the standards mentioned in the architecture. So what can we do in these situations to ensure the work continues to be done? How do we address it? You know, different countries, and I think we all recognize this, are at different stages in their data governance and digital health maturity level. So how does the standards set out in the proposed framework, how do we address this situation, and how does it work for different countries in different contexts?
Sure. Thanks again, Kristen. Hi, Abhishek. So yeah, I think that's an excellent question. And we ran into that discussion as well. And this is a reason that we are calling this as a reference framework. It is not the framework. A reference framework that countries can look at and adapt to their context and setting and maturity. And like Kristen mentioned, there are in some countries there are the digital health maturity sort of index available. If not, you can definitely look at them as well. But the idea would be that. Sorry. But in terms of the implementation, the ideal step would be that the country teams led by the ministries can look at the reference framework, and based on the context, the priorities, and the need, can agree on a minimum set of standards. So we're not saying that all of these should be applied, but identify the minimum set that can be applicable for each country based on the resources and the context and the priorities, of course. And that would help define a country-specific framework. So that probably would be an ideal way to go and make sure that again, we look at it, prioritize what we need to improve for now, and then in a couple of years look at the second set and maybe expand. And I completely agree. All of them will not be possible to implement in the first sort of round, but we can have a phased approach where we can prioritize our set of standards. Then in a couple of years we've achieved them. Then look at adding others and work in that sort of a phased approach. Thank you.
That's great. Thank you, Vikas. Any other questions from those in today's session? Would love to hear your perspectives as well of what you're seeing at national level or within your organizations. What are some of the challenges that are being faced when it comes to, governing health data, ensuring the right frameworks are in place for that, as well as any good practices that we can kind of really share, which would be useful, for other countries as well as for the global framework that Vikas has presented. Any opportunities you see as well for kind of moving forward with the framework, and how it can really support countries, and any opportunities for that as well? Any thoughts from either from, also from the HDC and from UNAIDS? Yes.
Kirsten, just to add, thanks. I can share some work that's happening in Sri Lanka that, where we kind of find areas where there may be challenges. For example, as we develop the global reference framework for health data governance, and as we try to look at it and from a very high level, we also see that different countries are at different levels of maturity when it comes to addressing this health data issue. And I think that links up with Abhishek's question of low resource settings, how data governance may be adapted and what can be done. So I guess we, in a way, we see that there is a need to go at the pace in which the countries are prepared to address these issues. And at the same time, each context will have its own strategies as well as own ways and means of addressing certain issues. It may be taking more time. It may be that certain areas could be implemented while the others will take time when it comes to addressing. So I guess there may be different strategies at each country level in addressing this. This is something we are experiencing now. And of course, each country will have its own ways of overcoming these issues as well. But I think it's what we are trying to address through the global reference framework, also to incorporate these experiences and try to address it at some point in time.
Yeah, that's great, Pandula. And I think as well as that moves forward, to continue to share those experiences from countries as they take that forward, which is a great kind of examples and, learnings for others as they're embarking on that journey as well. Thank you. I see, Craig, you have your hand up.
Sure, thanks. Thanks, Kirsten. And apologies for being late to the call. I got called into something, so sorry for that. And it's great to see everyone here. Ali, thanks for leading this together with Kirsten, and thanks, Vikas. I kind of two main thoughts, Kirsten. So one is the data governance framework that's been highlighted and is being worked on is really useful, and I'm going to say at global level, which has an impact on country level. So firstly, at global level, there's another stream of work which is beyond health, which is looking at data governance, which was asked for by last year's UN General Assembly. And there's a stream of work coordinated by UNCTAD and a group of member states, which will present back at next year's UNGA. And I mention that because this framework has been highlighted, and the work of Transform Health has been also highlighted in that process. And that helps, in my view, bring together much more greater variety of sectors and views on data governance. It gets us much more closer to national statistics offices, for example, and from a UN perspective, helps us coordinate in a much broader fashion. This type of arrangement on data governance broader than health can actually help bring together multiple UN teams. UN resident coordinators in countries, for example, can do and say things that a simple WHO office can't say. So it helps bang our heads together in a good way, looking at data as a strategic asset. And we're hoping that through that process, this process, through the health data governance frameworks being developed, we're going to contribute that on behalf of the HDC and WHO and you to make sure that people are more aware of this as well. And people are looking forward to hearing some of your ideas as well. The second thought that I had was really how to apply it at country level. And I think Pandula highlighted a few. And I think one of the most important things to look at is the way in which countries themselves plan, finance, and being embedded in their government mechanisms through one plan, one fiduciary framework, one way of ideally monitoring and evaluating things as well. So most countries I'm aware of meet at least once a year to review their annual health plan. And that is an opportunity to look at data governance issues and adapting, and I say adapting or contextualizing something that arises at global level, such as this global level governance framework, of which there are different components, as Vikas has highlighted, that could be useful for ministries of health, but beyond that as well, to look at aspects of the adapting the health data governance framework to their contexts. And I think in that, it's about embedding, like is outlined in the Lusaka agenda. It's working with governments and using their processes and timelines that's convenient for them as well. I do see one area which is perhaps the hardest area to work on, and a colleague just mentioned that, and it's working in fragile settings and with mobile populations, communities that are left behind, that are not living in an area that is governed well by governmental institutions and reliant on either the private sector or NGOs as well. So one of the things that we've been exploring is how to, and I know Transformative Health has done this as well, is to engage with something like the civil society engagement mechanism for UHC 2030 or other local mechanisms that encourages civil society or NGOs to actually be part of that process. So it's having a spirit of collaboration to invite NGOs and private sector to the table to adapt and look at the ways in which they're capturing and using data that can be used for action. So those are just some ideas, Kirsten. And again, apologies for not being here at the beginning. Thanks.
No, those are great reflections, Craig. Thank you. Picking up on just a few of them, maybe starting with the last one, I think there's a really important point you make of engaging different stakeholders in this discussion as well, including civil society, and realizing that while governments ultimately have the responsibility to ensure those frameworks are in place, when we're looking at governing data, we're talking about people's data, and they need to be part of those conversations as well. But it also impacts other stakeholders that might be collecting data as well, and how we ensure those frameworks that are applicable and respond to the needs of populations. So a really good point there. Actually, one of the things just to mention that Transform Health is working on as we work within this space, one of the areas is engaging communities so they're aware of their data rights, the importance of data governance, and these issues through a campaign we have called My Data or Health to really kind of increase that awareness and action and more active engagement around those issues, which is really important. Also kind of reflecting on the balancing, having those broader discussions on data governance and how that can also support and moving forward as we look at health, but then also looking at what are, I guess, the specific things that need to be addressed more broadly, but then specifically on health data as well. And I think particularly the topic of today's session and looking at HIV and sexual and reproductive health and rights really highlights the need for health-specific governance and protections as well, given the particular sensitivities around that data. So completely agree that kind of these broader discussions can help move it forward, and then what is needed to really ensure the right frameworks in place when we're looking at more sensitive health data. Let's see, we have a couple of hands up. Over to you, Abhishek.
Hi, good morning. So I just want to share a reflection that, the slide, first of all, I really like the slide that Vikas shared. It just gives a really good summary of the things one needs to watch out for. My reflection is that, a lot of the elements are tech on that slide, data collection, AI, security and all that. And a lot of good tech is available. So I suppose, it's about how we can make the communities aware of what is available out there. So I think that's one, that's maybe a missing piece, or sometimes, we don't do that well enough. And secondly, it's about sustainability. Because, once you take the architecture and you get down to the nitty-gritty of actually doing the work, then you will realize that at the end of the day, it's all contracts, right? It's a contract with a vendor, so questions like who will fund it and how can we make it sustainable? How can we make the communities more empowered so that they can sustain it? I think those are the two reflections I wanted to share. Over. Thank you.
Yeah, those are excellent reflections, and I couldn't agree more. Really increasing not just the awareness of communities, but really ensuring they're empowered and can hold their policymakers and decision makers accountable as well, which kind of lends itself to one of the questions we wanted to ask to the whole group is kind of what is one enabler for sustainability? So you've mentioned one there around kind of community awareness and empowerment. Thoughts from any others on the call around kind of what are key enablers to ensure sustainability? And Ali, I see you have your hand up.
Yeah, not to give an answer on that question, just to give an update that unfortunately Dr. Joyce from Kenya had to attend a session of Parliament on the actually on data governance and couldn't leave earlier. And I'm Mr. Mwango from Zambia is going to join in a minute or so. Thank you.
Fantastic. Yeah, if you just flag as soon as he joins, and then we can turn over to his presentation, that's great. Yeah, any other thoughts from others in terms of kind of what are those enablers from sustainability? So we've heard about community empowerment and awareness. Any other key factors to ensure sustainability? Also looking at kind of what's key to ensure moving from those frameworks on paper into practice. And we heard some examples also from Craig on that. And then what's needed to ensure the sustainability as well. Lots of people on the call, so I'm sure we have some really good country examples and thoughts and experiences on this. Maybe to add to that as well, any thoughts on kind of how do we balance some? So one thing that comes up a lot on debates around health data governance is how do we balance the issues around confidentiality and protecting data and the need for integration and the use of that data to improve public benefit and health outcomes? How do we balance those two? Any good examples from countries or other experiences around that? Anshu.
Okay, thank you. Just sort out my audio as usual. Good morning, and really thank you. This is fantastic discussion, and it's really the right time. It's a lot of work, and in WHO we also, with the HIV team, we were also discussing on the how to the unique ID, but a lot of it linked to the data governance. And HIV is a very special case. So this is very interesting. I really like your question, Kristen, and this is one of the areas that has been implementing the system in the country. And as Bishak said, a lot of when we implement, we focus a lot. Number one is the software, the digital side. And I think we need to shift that view from looking at it as an entire architecture. If you want to collect the data, what needs to be involved, and the governance should be the first thing we have to think of. I've done some of the work with the routine data, which is now expanding a lot into individual levels, and which is more on the issues of how we're going to register people, how we're going to make sure that they feel confident and trusted enough to give us the details, and how we're going to make sure that all the procedural that is required to get the data through are properly regulated and checked and enforced. And so the framework that Vikas presented is exactly what is required, but we cannot wait to have that all done at the same time. So we are now closing up the score assessment for health information system of that data governance, take some part of the highlights in the assessment. And one of the areas that really challenging and most governments do not want to do is sharing data and open data. And I think if let's see, a lot of that is linked to these discussions. How we to guarantee the security, the confidentiality, the trust that is built throughout the process. And then the regulations. More on that also, how we're going to not just the community, but also get the governments involved and be the owners and the leader of the data system. Until we get that answered, the sustainability question will never be answered. And it's a challenge because, it's to me, I've seen that the entire data governance and the system and the structure of data system has been overlooked because of all the tools and because of all the investment by the donors and the partners for the right reasons, because especially for like HIV with the global funds and with PEPFAR. And I really hear Mary's, because now this is a wake-up call for us, but how far of it we're going to change the understanding that if we do not lead it, and then somebody else will come and do it for us. So it's the transitions of how we bring the data and the use of it, and that link with the accountability and the transparency. And I think I know this is quite a big thing to discuss here, but like at the country implementation, let's start with, if we have a system that it's owned by the government with a proper legislation, with a procedure that is regulated, regularly updated, and now we have enough materials and resources out there to guide of, if you set up a system, what is required, who should be the roles into that, what is the role of the government. And the work of HDC in coordinating and make sure that all the partners in the HDC or in the country should follow that leadership in the country. I know it's not perfect, but we can work together and to make it better. And that's the main thing. Thanks.
Thank you, Anshu. Really, really important reflections. I think a lot in there, but all absolutely needed. I think really emphasizing, I think what you said, the government leadership, but also the role of communities in there. And I think so many, whether it's the advance of digital health systems, AI now, what's happened recently with data systems, so many of these issues really highlighting the need for and the urgency for the action to really address this. Moving beyond, we have a lot of the tools, we have a lot of the guidance. How do we really put it into action now? And maybe just 3 things I think really emphasize words that I want to pick up from what you said around the importance of transparency, accountability, and ultimately trust, which is needed within these systems. So thank you so much for those reflections. I understand, and I think I've just seen we now have Dr. Joyce Mumwike who's joined. Joyce is from the Digital Health Agency from the Ministry of Health of Kenya. And she will share some of the experiences from Kenya, in particular around the Afya KE and the unique patient ID for HIV continuity of care. Over to you, Joyce. Would love to hear your reflections, experiences, and what's progress within Kenya. Over to you.
Dr. Joyce joined, but it looks like she dropped again.
Yes, I'm not seeing her right now. Okay, maybe we then can continue a little bit just with the discussion in the caller, Ali. I'm not sure if you want to take it from. Or do we have Mongo? Has he joined? No.
he was trying to join as well, but I haven't seen him joining. It's quite unfortunate. Oh, no,
joined,
I think Mwango just joined.
Fantastic. Welcome, Wango. Great to have you here. You've joined just in time. We have Mwango Mutale, the Chief M&E Officer, RHIS from the Minister of Health, Zambia, who will share some of the experiences from Zambia with the Community Health Information System. So over to you, Mwango. Are you there, Mwango? I think I see you there.
Yeah, so sorry, I'm just joining in.
No problem. Thank you for joining us.
Gotten out of another meeting.
Great. Over to you to share some of the experiences from Zambia, and particularly on the Community Health Information System.
Thank you very much for this opportunity to present to you and just to share some of the things that we are doing in Zambia concerning the Community Health Information System. So I think I'll give a brief background to indicate where we are coming from and where we are and where we envision to be. So I don't have a presentation to share, but I'll just share some notes. So as you may be aware, as a country, we've had strengths in the facility level health information system over a period of time. And this was necessitated by the changes that had earlier started in the 1990s that led to the health reforms. So one of the things that came about during the health reform is to have a functional health information system. But when it came to the community health information system, we lagged behind due to the policy direction then in the 1990s. But later on, we sat as a ministry around 2000 and around 2012 to come up with something that we were calling Community Health Information System. But its rollout, I must mention, had protracted due to a number of issues, because we didn't have people to collect data at community. We didn't have even the tools to guide the data collection at community level. And this led to a wide assessment to establish some of the things that could help us form and set up this community level information system. And by 2017, we had an interim review of the community health strategy, which clearly pointed out that community health information system was lacking in Zambia, which led to the revision and the development of now what we are calling the community-based health information system. So it's twofold. We have the electronic component of it, which we are calling Community Health Information Platform, which we are currently implementing in 5 districts these districts are in 4 provinces. So the Community Health Information Platform, which is the digital component of the community-based health information system, empowers the community-based health information, the community health workers with gadgets or tools to collect data as they provide services in the community. So we have trained our community health workers in this package called Community Health Information Platform. But we have also trained the wider area where we are yet to roll out the chip. So for those far-flung areas where we have network issues, we are still in the process of transitioning to the chip, which is a digital platform for the community health workers. So far, we have plans to roll out to other districts and to other provinces with areas where we have a stable network, we have stable power. We are rolling out come 2026 so that we have a wider coverage of this community health information platform. So far, this is what I can say for now. I missed out the earlier part due to connectivity issues, as I was also transitioning from one meeting to another. But I'm here to share more light should there be any questions that the audience would like to put across. But in a nutshell, that's what we are doing as Minister of Health. So, yeah.
Great, thank you, Mwango. Happy you were able to join us despite some difficulties with some tech and joining. Any questions for Mwango based on the experiences in Zambia with the Community Health Information System? Maybe I'll just ask a quick follow-up question and kind of any challenges that you've seen with this and kind of how you're looking to address those and kind of around implementation and moving forward.
Yeah, thank you very much. So some of the challenges that we noted is the issue of having siloed partner-supported types of systems. But what we have done is that the chip is more inclusive. So if program comes up with a particular program need or indicators that might be missing in the chip, we sit together with the program to look through the community service package, which the community health workers are using to provide the services. Is it among those the services that the community health workers are doing? If it is part of that, we quickly sit together and also align the chip also to capture some of those elements that are missing. Largely, that's one of the major challenges, but we are addressing it, like I've mentioned, that we sit together, we interrogate some of their requests, also some of their proposals relating to data collecting, but also the issues of partner support that was paying the community health workers to collect this data. So through the support from the government, we are now paying the community-based health volunteers a stipend every month. This has also helped now also capture a number of community-based volunteers to support the services in the communities, but also to collect the data within those communities. So the other thing that is there is that we never had standard training protocols for our community health workers. But now what we have done is to integrate and have an integrated package for the community-based health workers. And these are now called the polyvalent community health workers who are taken through a wide range of services, and also M&D is part of those packages that they are taken through. Yeah, so I think that's the comment for now. Yeah.
That's great, thank you. And I think that responds to as well earlier on, we had some questions about what this kind of means at community level. So great to hear those experiences from Zambia. I see we also have now, just to clarify, we do have representative from Kenya. I just want to double check because I see that we do have Dr. Joyce now on, and just wondering if you're able to speak or if it will be Dr. Jacob.
Okay, so good afternoon, good
Fantastic.
morning, and I'm so sorry.
No, not to worry. Welcome, Dr. Joyce.
So sorry. So you are, I can't speak, but if Jacob is in, we can do, I mean, you mean the Dr. Jacob from Kenya? Is that what you're saying?
Yes, yes.
Yeah, so we can do it together.
Okay, fantastic.
In between a meeting, but this is important, so.
Great, well, we're honored to have both of you then.
Yes.
So just
so
we
I put my video on so that
Perfect.
you can see me or something. Fantastic. I don't know whether I'm being seen.
Yes, we can see you.
Okay.
And thank you so much for joining.
Yeah.
So yes, so we have Dr. Joyce Mumweke from the Digital Health Agency, Ministry of Health Kenya, and we also have Dr. Jacob Odiambo, sorry if I pronounced that incorrectly, the program director for Kenya HMIS project under Palladium in Kenya, who's working with the Ministry of Health in facility digitalization and health data governance. So welcome both of you. Would love to hear the experiences from Kenya, and I believe particularly around the Afya KE and the unique ID for HIV community of care. Over to both of you.
Okay, so I'll give a very high level overview because you've just said you want to listen more to Afya KE and unique identification for HIV, but I'll start with just talking about what we're doing. So I am, you've introduced me pretty well. Here I'm commonly known as Dr. Joyce. I work at the Digital Health Agency. It's a parastatal or a semi-autonomous government agency that is in its year 2 of operations. This agency was established through an act of parliament called the Digital Health Act 2023, for which I was the technical lead. And subsequently, we also were able to gazette digital health regulations 2025, sometime this year in April. So the digital health regulations are 2 types. So there is the health information management, and in there is everything to do with data governance and also certification of digital health solutions. And then the other regulation is on, it's called the data exchange component. So it is with these 2 legal frameworks, plus very many policy documents and digital health related standards and strategies that we are now able to do what we are calling the digital health transformation initiatives in the country. So because I know this is about data governance, I was told to prepare for data governance. So we realized a few years back that we did need a data governance document. Initially, we had documents related to this is how you define this particular indicator, this is how the data should be collected, and then collated into what we were calling DHIS2 then, but in our country, we now call it KHIS, Kenya Health Information System. And we realized there were more questions coming up. Like, for example, should data be put in a cloud, for example? Should it be hosted in the cloud? If somebody requires individual level but de-identified data, should they go through the Data Protection Act? Because we also realized people were misinterpreting our Data Protection Act 2019. So even when someone was asking for aggregate data, you'd be told, no, the Data Protection Act says you cannot. And then there were now emerging issues related to actually aligning to the Data Protection Act, to things related to data sharing agreements. There was this question of, is there a generic data sharing agreement that should be given to partners, that should be given to whoever wants to share this kind of data? To what level should it be shared? There were so many questions. So we came up with a data governance framework. It's a document that has been in development for quite a number of years, because in between, we then had to work on the Digital Health Act. But this is what we learned. Because we had already thought through so many data governance related issues, it was easy for us to write our Digital Health Act, at least from the perspectives on data governance. We did know that we needed a data governance framework, so we put it in our Digital Health Act. So it is in there that there shall be a data governance framework for Kenya. We were able to define what is this health data. You know, people always, you know, we used to think that we are communicating, talking about health data, but the legal team said, no, you have to define them. What is health data? And we discovered even administrative data. Yes, it's defined out there, but to what level of administrative data should be shared, should be collected, all that. So we were able to put it all in the Digital Health Act. And then further, when writing the regulations, as I've alluded to, there is what we call the health information management, I would call them regulations, part B. We have detailed, like if someone wants access to their data, what should they go through? What is the period? You know, of course, we've aligned it to the Data Protection Act. Ensuring if I need correction in my data, what should happen? Then at health facility level, what are the expectations? Registration of data processor. You know, the Digital Health Agency is supposed to know who is processing health data in the country. Then things to do with digital health solutions. There are so many. How do they get to work within the Kenyan ecosystem, digital health ecosystem? The whole bit of you shall have to go through certification. And of course, as I've said, our regulations also cover that part. So that's on data governance. But zooming into the question of unique ID and Afya KE. So in our country right now, one of the core things that we are doing is we appreciate, and I know even all of you will appreciate, that as long as you have not digitalized health facilities, then we are not talking anything digital health. The facilities is where the data is collected. For a long time, we have had many of our facilities run on paper. If the facility is offering services to the HIV clients, then you find that facility is in two parts. There is one section that is heavily digitalized, and then the rest of the facility is paper-based. So the question has been, do we degrade the the digitalized corner, you know, the comprehensive care clinics down back to paper, or do we bring the manual up to be digitalized? I mean, for the whole facility to be digitalized. So that was the number one thing. But the number two thing was already there are so many systems, there are several systems that have been used. Do we do away with them, or what happens? So in KEM, we needed to figure out how to digitalize health facilities. We have about 10,000 operational health facilities, but we have a bit more, about 16,000 total that are, actually it's 16,000 operational, but 10,000 are running on our social health insurance. They are contracted by the social health authority. So, and out of those, about 6,500 are public. The rest, a good number, like 8,000 are private, and then the rest are FBOs and NGOs. So what do we do? So we took up the Kenya EMR 3.x. There is also Afya KE. There's another one that we've come up called Tibabu, and there's another one that we are building for level 5, 6, and we are calling them a suite of solutions, but under a banner called Taifa Care, Hospital Management Information Systems. Now the question was, how will these systems speak to each other? You know, there's always that, how will they speak to each other? So that is being done through our health information exchange. Because of the work we've done regarding programming for HIV, and we've had that possibility of learning a lot through the many years that we've been doing HIV programming, we know that for systems to speak to each other, there are certain core things that must be in place. How you identify the patient, for example, the person receiving care. So we do have a client registry. Right now, it has 27 million Kenyans in there. And we've identified, you get into the registry currently either as you register for the social health insurance, or as you register for what we're calling a patient portal. It's called Afya Yangu, meaning my health. So you can get in through those two. Originally, when we were planning and designing all this, we also thought you should get in through a HMIS or even through another health insurance provider. But we are just going it systematically, just to make sure that we know where the data is coming from and we can do quality control. Then the second thing is about health facilities. We already were there as a country. The only thing is our health facility registry was, what's the opposite of dynamic? It was static, yes. So dynamic, we needed, COVID showed us why we needed dynamic. Because we were using Excel sheets to really know about things, administrative data like number of beds, ICU beds, for example. We were using Excel sheets. But now we have a dynamic master facility registry. We've moved from what we were calling MFL code to now one that is called facility ID. And we've built it in such a way that it allows for expansion. For example, we are now foreseeing at some point we will have virtual health facilities. So how will they be recognized in terms of facility ID? In the same facility registry, we are now currently onboarding ambulances, because many people forget ambulances, yet they are a core component of health service delivery. So ambulances are coming in. Then at some point, we will bring in community pharmacies, community labs, and we'll have this huge registry that has two components. There is a component where the providers can log in and update key data elements, like maybe the tests you offer if you're a lab, or the beds that you have, the health workforce that you have. So it's all there. So today, right now, I have a dashboard that I can click into, and I see even beds availability by normal beds, ICU, HDU, and baby cots for NBU. So we do have that, and it's been really interesting because it's also pushed now the policy. I know it sounds funny, but in our area of the world, people share beds in hospitals, in public facilities. So we've returned that dignity. We are saying one bed, one person. So now a facility cannot have two people in a bed because of that component. So that's a facility registry. The third thing is to identify the healthcare worker providing services. So today we have a health worker registry. Joyce is a doctor. If I'm not up to date with my regulator, I cannot transact business in the digital health system. So that the Digital Health Agency has built. So we do have that. It's also helping us be able to do things like pre-authorization approvals using some mHealth applications. So that is already there. The other one is the community health registry. We have community health promoters. So we already had that, but now what we are doing is enhancements, like defining what does an active CHP look like? So that is what determines who should be paid at the end of the month and who should not be paid. And then we have a terminology space or terminology registry. What I'm really proud of currently is that we have our product catalog up and being used by the various systems that we have in place, specifically the system that is, we call it Share Provider Portal. And then the last one is still work in progress, but is now the one that ties everything. We envision having a digital health file for every Kenyan. So we call it shared health record. The word shared is a misnomer because people think, oh, my records can be seen. But we are trying to reconsider how it's called. But basically, I'm sure you know that that's the patient file. So when it comes to the HIV clients, initially, before this current client registry that we have, we had already done something similar, but small scale. So for HIV clients, long before, we always knew we needed to identify them uniquely. But we started at facility level. You could be able to tell about facility level, but because facilities were not connected, you couldn't tell when they go and get another number. Then now came in our first trial at a client registry, and we were able to do it. And that is what gave us impetus and confidence to now build what we have. Obviously, maintaining a client registry is a lot of work, ensuring that a person who should be there is there. They are given a number called CR, client registry number. When you die, we haven't yet linked up to the civil registry, because when you die, you should be able to be put in another folder. But one thing that we've been able to do, and that I'm also particularly proud of, is You see, in our part of the world, we have lots of teenage mothers. These teenage mothers do not have the national ID for obvious reasons. They are minors, they are less than 18, because our client registry is built on the national ID concept. So, and birth certificate number. So a lot of these two documents will not be available to a teenage mother, either because she's run away, she's alone. So we have what we call temporary ID, temporary health ID, and we put it in a different folder. So I can speak so much about that, but in essence, Kenya is in a space where we are doing a lot of reforms. It's not something we thought about yesterday. It's been a lot of thinking through for the last couple of, like 3 decades. I'm always asked, should countries have a digital health agency? I usually say, when you get there as a country, you will know. You will know that you need to have an agency. For us, we got there. We can always discuss another time the signs that we saw, why we needed the agency. But one of the things is you need some autonomy when doing some of this work. You also need a way that you can have what I like calling sustainable financing for digital health. So as an agency, if you look in our regulations, they are online, you can go and see them. We do even have fees that we are going to charge upon usage of the system. So we haven't started actualizing that because we are still building and still want people to appreciate, the providers and the clients to appreciate why the digitalization is important. But yes, we are going to start charging fees because all this is not free. Somebody has to pay for it, but we've come up with innovative ways of how that can be done. And then data governance remains at the core. We always have to remember the 3 principles, the key one being, protecting people. The question of data privacy, data confidentiality is always coming up. Is my data safe? And that's one question that keeps us awake. And personally, I don't even like responding to it because we are always, that's another whole area. And ensuring that people trust the system is a big, big job. And then the documents that we have really laid a firm foundation for the work that we're doing. But above all, what makes the difference is we have the highest political will from the president to everyone else who needs to be part of this. So I submit, and Dr. Jacob can now come in and talk about HIV. Thank you. And once again, my apologies.
No, thank you. Thank you so much, Dr. Joyce. You've raised some really important issues, but really shown not only recognition of what some of the challenges were, but really, as you've just ended now, is really the importance of having that high level political leadership to make sure the right systems are put in place to address those challenges and what's needed. And I think particularly important, which we've seen in Kenya, as well as many other countries, is the importance of really legislating and regulating this as well. So it provides those legal and regulatory guardrails around what is needed. So thank you. We're getting I think we're at time, but I think, Ali, if you said that was okay, maybe we just pick up quickly one question in the chat, which then lends itself to kind of coming into the specific example around HIV. That's a question from Craig around what impact do you think a program such as HIV can influence the broader health data governance agenda, especially on engagement of NGOs and data sharing, for example. So maybe if we still have Mwango on the call, maybe I'll go over to you first, and then Dr. Joyce or Dr. Jacob, whichever of you wants to take it. Mwango, over to you. And if we can just keep it a kind of short, because I know we are at time, and we'll just wrap up in the next 5 minutes or so. Over to you, Mwango. Do we still have you?
Do I respond or?
Yeah, maybe. I'm not sure if Mwango's still on, but yes, feel free to come in, Dr. Joyce.
Yeah, but Jacob will speak. So, okay, I'll speak from a personal experience. So a lot of the things that we have in our Digital Health Act, in the data governance framework, are things that are scenarios we came across. I used to be the strategic information lead at our national AIDS program, and we were working with Dr. Jacob before he moved to Palladium. And the things you find in there are some of the scenarios we face. Like, should we release CanFIA data before it's fully analyzed? Is it ethical? Is it right? You know, there was always this push of, you've done a survey, at what point should you release it for at least some program, some core programming, compared to when you release it for, you know, the launch? Should you keep the data until the launch? You know, those things. And if you're to share the data, then how should it look like? The issue of parallel systems, you know, there is KHIS and there is DATIM and there is another system. How do we make sure that there is some sense of sanity? Because at some point we used to have different numbers from each system. So how do you bring that together? And then things like, you know, right at health facility level, if the vendor or whoever has a system locks up and goes, you know, they don't tell you they have gone, they go, you just discover they have gone. Then you have to rebuild all that data that had been collected through that particular system. What happens? So that is why we have in the Digital Health Act that, one, we have to know who's dealing with health data. They have to be registered. Secondly, we are building the system in such a way that we should have some copy of that data. You know, and the shared health record is one, but at county level, we are also looking towards having things like county data banks, where we encourage providers to every once in a while back up at the county data bank. But if you disappear, we can still start from somewhere. I've been involved in what is it called? Rebuilding data of patients who have been on care, HIV care, and you couldn't, you know, you just have to rely on them telling you, I've been on this, because the data was not there. So it does help. It not just does help, it really contributed a lot to the insights that we have in our current documents. But Jacob can pick it. Thank you.
Dr. Jacob, would you like to come in?
Yeah, I think Dr. Jess has really covered it, but I think what the HIV program did was to give us experiences of what we need to prepare for in the future, modernizing our data protection laws, but also handling the systems in a way that facilitates the delivery of services while protecting person level data. I think the final comment I wanted to make is that when it comes to unique identification, what the HIV program also taught to us was that unique identification is really what links the individual level data to the person to whom the data belongs. That data subject in our data protection laws has really been empowered in our Data Protection Act, which means that once you link that person's data with that person, the data belongs to them, and they are very powerful in that regard. So they need to be protected, but also be empowered to basically provide control over who accesses and who does not access their data. Then finally, it's just about the initial resources we use for Kenya's data governance framework actually came from the HIV program, right? And then over time, then the Ministry of Health adopted those in order to translate the principles of data governance into the practice of governing data. And that is what gave birth to the regulation that Dr. Joyce talked about, through an MOH-led but participatory approach. So that's it from me. Thank you.
Thanks so much. Yeah, I think that's a really important point of really ensuring that, you know, as frameworks and policies and laws are developed, it's really informed by the needs and the realities and scenarios in the country. And then, as you said, kind of that government leadership, but then making sure communities are also empowered and part of that discussion to ensure it responds to their needs as well, because we're talking about their data ultimately, which has come up a couple of times during today. Mongo, I don't know if you want to come in from some quick reflections. I'm not sure. Oh, I think we've lost Mongo. So I will hand back over to Ali, because I know we are a bit over time to wrap up today's session.
Thanks a lot. Kirsten for the great facilitation, and a special thanks to our colleagues from countries, Mwango, Dr. Joyce, Dr. Jacob, really great insight from countries, and how Zambia and Kenya has strengthened their data governance. I'm supposed with the impossible task of coming with 2 or 3 highlights from the meeting today. It's so much to digest, especially the presentations and the country experiences. I cannot do justice to that, and I will not try to do that. But a couple of points that was highlighted was so the importance of the legal and policy framework. We need them. We need them to be the foundation of the work, but that's not the end point. We need them to allow and to empower the data owner, the data custodians to move forward. And one key thing that I think it's special for this call is that we hear a lot about the need for integration of HIV, HIV care and HIV information, all the HIV systems into the broader health one. And it always comes with the question that, all right, then, but they're not at the same level. How are we going to do that? And this is a great example that by integration, it's not a one-way pathway, it's a two-way pathway. There are so many things to learn from these two and bring them together. So if we are talking about integration of HIV data here into the broader health information system, there are so many lessons to be learned, and the experiences that has been achieved through the HIV, huge investment in HIV data to bring that to the broader health data. So then all those investments will not go into vain when HIV data is integrated supposedly into the broader health data systems. It brings on all the lessons, and Dr. Joyce was a good example of moving from HIV to the broader health. And maybe as the last one, going back to HDC and the working groups, one of the key roles that HDC is to play is to be a place for knowledge sharing and for being a repository of knowledge from countries. And I think it's important to highlight that role here. And as a member of HDC, I think I can speak on behalf of HDC that it would be great to collect all these experiences, the documents. As an example, Mwango already shared some good examples from Zambia. We can collect all of them and make sure that everyone in the call and those who were not fortunate enough to join this call can access to them. And then one last point is that this is not the end. We will continue that discussion, not only for HIV, but at the broader level, but make sure that everyone is on the same level and same page. With that, we're almost 15 minutes past the timeline, but I think for me it works the all that time. With that, I would like to thank you. Thanks again, HDC, for providing this platform to have that discussion. Thanks to Christine and to Vikas for the role played, and special thanks to Pandula and Craig. Thanks a lot. Have a very good day.
Thanks, Ali. Thanks, everyone.
Thanks, everyone. Thank you. Thanks.
Thank you.
Thank you.
Thank you,
everyone. Bye-bye.
everyone.